where is localized maximum painful part of the right iliac fossa. In case of this sign is positive in case of acute appendicitis. Typically, typically appendix localized in the right iliac fossa, but you must remember, on my practice, I saw maybe 3-5 cases when the appendix localized in the area of the umbilicus, and 2 cases when the appendix localized left side. That is why you must remember, in case I think shifting or signs of shifting or moving pain can help you to confirm or rule out this diagnosis, because pain localized in epigastric or periumbilical region, and after that shift or move to the area where is localized appendix. When the pain migrate to the right iliac fossa, I think it's really acute appendicitis. When the pain shift or move to the periumbilical region, it's usually maybe suspicion on acute appendicitis. Sometimes maybe shifting to the pelvic region. I saw 2 weeks before when the last week when the young girl suffered like this problem. She was admitted with the signs of pelvic-peritonitis. All the signs of peritonitis are positive. That is why to determine other signs is impossible, because if you try palpate, pain present, turn to the right, pain present, turn to the left, pain present, T-shirt sign is positive, Razdolsky sign is positive. After the beginning, after 8 hours, all the signs of spread peritonitis, but one sign was pain start from epigastric region, and after that migrate to the right lower region and to the pelvis. That is why I shown to Dr. Gynecologist, first of all, to rule out a rupture of the cyst with complications, exacerbation with purulent cyst to abdominal, because very rapid beginning and spread peritonitis. On ultrasonography it was a lot amount of fluid. After that, Dr. Gynecologist to perform punction of the Douglas pouch and aspirate white yellowish pus with admixture of seroso-inguinal discharges, and smell, absence of colibacillus smell. That is why the doctor gynecologists don't show you, is it gynecological problem? But I thought the presence shifting pain. That is why I was transferred this girl to our to surgical departments, and head of the surgical departments to use laparoscopic investigation to confirm or rule out gynecological or surgical problem. She insert camera above the umbilicus, visualize purulent peritonitis in pelvic region and spread to the right flank, and after investigation he was determined phlegmonous, change appendix, dilated distended appendix covered with fibrinous filament, and was made laparoscopic appendectomy and carefully to laparoscopic toilet and cleaning and washing abdominal cavity with antiseptic and insert tubes. And now excellent post-operative period. She is walk on corridor with his friends, boyfriend, normal temperature, normal recovery, and best cosmetic result, free small skin incisions. Because in case, for example, when the surgeon was made open type of surgery, McBurney's point opening, after that to recognize destruction or destructive appendicitis, but a lot of amount of pus, what must do surgeon?
Drainage.
Not only drainage, and surgeon must do carefully toilet. In case of spread purulent peritonitis, the law in surgery, the rule of surgery, midline laparotomy and perform carefully toilet and insert tube and surgical glucose drainage in the right iliac fossa and left iliac fossa. It's minimal. When the purulent process extend to the right flank, one more drainage.
Three.
1, 2, 3. On laparoscopic, 2, and good cleaning. And our head of the surgical department was prescribed serious antibiotic, TNAM. It's cephalosporin last generation. 500 grams. 1 gram of this. 1 gram of this. Or daily dose 500 grams. Understood?
For how many days?
What is the medium extent? No, in this case, 5 days. 5 days. Okay. First of all, Bartholomew-Michelson sign. You are determined where is localized the point and area with the maximum pain. Okay, the pain maximum localized here. Doctor, in this part, it's very painful. Why you touch me? Why? And after that, don't interrupt your hand and ask the patient, please turn to the left. Don't interrupt my hand. And after that, perform continuous or repeated examination in this point. The pain of the left side is more severe if you compare the pain on the back. It's Bartholomew-Michelson sign. I'm trying to explain. Of usually appendix cover with omentum and intestinal coils localized here. That is why when the patients turn to the left, slide away omentum, so slide away intestinal loops, and your pressure will be directly to second with the inflammatory change appendix. Next. Rovsing sign. First of all, you must determine sigmoid colon and fix to spine, to bone, iliac bone. And after that, some doctors to use continuous examination by left hands, but for me, more comfortable to use right hand. I'm change hand, and after that, pushing movement to the right side. And after that, the pain is more severe in the right iliac fossa or appearance in the right iliac fossa. Rovsing sign is positive. Okay, Obraztsov sign. Вставай. Obraztsov sign or psoas sign. I ask one more student. Before the examination, you must explain patients how must he show this sign. When I will be perform palpation, you must write your right lower limbs without flexion, only strengthening, and you cannot help. You don't help, not help to patient. Please. Oh. Do you feel any pains?
No.
No. During palpation, when the patient rise right lower limb, the underlying musculus psoas will be due to high tension. What is this?
Like it's a compress to the appendix.
Правильно. Okay. Palpation, underlying musculus psoas will be dilate, and pressure to appendix will be more. That is why Obraztsov sign or psoas sign positive or negative. Now the surgeons know about 120 signs concerning of the acute appendicitis. But on real life, what do you mean? Will you use 120 signs?
No.
In real life, we are use only 6, 7 in non-clear, in doubt non-clear cases. We are use dancing. Танцуй. Your soul is dancing now, да? Правильно. Continue. Oh, that is why the surgeon, experienced surgeon, to save the time, own time and time of patients. And you must remember the time from the admission patient to reception room till operating table must be none more than 2 hours. if your diagnosis will be acute appendicitis without questions, after 2 hours your patient must lie on the operating table and you must start appendectomy. Understood? Okay. Next. Signs in case, turn to the left. Signs when the appendix localized in atypical, uncommon position. First of all, Yauri-Razanov sign. Yauri-Razanov in petit triangle, musculus erector spina, costal arc, this point. Do you feel any pain here? No. Yauri-Razanov sign is negative. In this point, you can to show signs Gabay. X looks like Shotkin Bloomberg. Press slowly, press inside, and after that, rapid interrupt your hand. When the pain is more, when you remove your fingers, Gabay sign is positive. Come back. One more sign, Cove. Relax. Rotation in coxofemoral joint, right coxofemoral joint. I think 3 signs enough. Okay. My next question. I ask about signs, how you can show greater curvature of the stomach. Ibuna start to show these signs, but my question was about concerning the acute intestinal obstruction, scleral. But he was started to show how you can determine greater curvature of stomach. This method is called Ausculta friction, if you remember.
Yes.
Apply phonendoscope in epigastric region, and after that, normally greater curvature localized in this projection, or maybe lower part. That is why you can continue your I don't know, rubbing movements, rubbing distally from this area. Opa, disappear. 1 point, the noises disappear. Oh, 1 more point, disappear. 1 more. That is why linear greater curvature, linear of the projection of the greater curvature here. Okay. One more question. At what places you can determine pulsation dorsalis pedis femoral artery, you remember, here and here. Magistral artery on the pass. In first interfingers region. Dorsalis pedis. I felt relaxed. First. Experienced surgeons can to identify through the socks. It's not necessary to remove. Experienced surgeons, and in case of normal pulsation. But sometimes when it's unclear palpable pulsation, sometimes the surgeons can identify and to think about pulsation and identify old pulsation. It may be mistake. That is why you must compare. Is it pulsation of patient or is it your own pulsation? And first of all, pulsation, you can start from the termination of pulsation radial artery, and after that put in this point. Is the pulsation same? It's pulsation of patient. If you cannot or maybe distinguish pulsations, it's pulsation of doctor. And one more point. Tibialis posterior, malleus, medial malleus, and behind the medial malleus, pulsation. For me, through the socks, it's very difficult to recognize pulsation. Oh, now I feel. Oh. Чувствуешь? Do you feel? Не знаю. На, попробуй. А ты стоишь, танцуешь. Так, что дальше? What else? Ah, yeah, I feel that. Well, very low. Да, on. No. It's not low, it's normal.
I am not experienced surgeon.
Very thin socks. Хорошо. Дальше. Science of acute intestinal obstruction. What are the science? Splashing sounds. I think it's very important science. Just one from them. One more. Val science. Val. Val. It's not symptom. Is a syndrome. Syndrome. What do you mean? In common cases, can you palpate small intestinal loop? No, you are right. You can palpate only dilated, distended small intestinal loops. That is why the beginning of Wall sign. If you can palpate small intestinal loop, of usually you felt dilated cylinder. Okay, I felt dilated intestinal loop. Okay, I felt. After that, you can continue to make percussion above this zone. And after percussion, tympanic note above this zone. It's wild sign. Palpable intestinal loop with a high tympanic note during percussion. One more sign. Big oblique abdomen of usually left side dilated, distended, and right side empty. It's called Bayer sign. Bayer sign. What is this? What is this? What is the problem? Bayer sign. But what is the problem? What is the name of the disease? Acute intestinal obstruction, strangulated type, volvulus of the sigmoid colon. Sigmoid colon looks like on car колесо. Tires. Sometimes I remember the diameter in case of volvulus of sigmoid colon about maybe 14-15 centimeters. Maybe tomorrow I'll show, on another week I'll show film from operating room.
Bayer is German.
Bayer.
Is German. Is it German?
German, I don't know.
German.
Is it German? Otto.
Huh?
Otto.
Outer.
The German.
I don't know German, but I know Bayer. But I think on real life, it's not only all the doctor to use his own on motherland names, because I think experience and clever things fly in the environment, and some doctors, or maybe this sign in case of volvulus of the sigmoid colon. On other continent, on this moment, other surgeon thinks, or it's maybe big oblique abdomen, it's maybe volvulus of sigmoid colon. Understood? Or in the research and measures, one doctor suggests penicillin, one more doctor was suggest penicillin too. Understood? I think it's maybe zone around the earth, zone of things, fields of things. If you some students or some people can connect with this to these fields and can give information. Understood? But this is эзотерика. Эзотерика. Хорошо. Что у нас дальше? Acute intestinal obstruction. One more. One more sign. Obuchov Hospital sign. I will not show the sign. During digital rectal examination, feeble tonus of sphincter and empty rectum. It's called Obuchov Hospital sign. Positive in case of acute intestinal obstruction. One more sign. Sign or test Tsege-Mantenfeld. Tsege-Mantenfeld. We are used conservative treatment in the case of partial intestinal obstruction or adhesion intestinal obstruction, we use conservative treatment. This conservative treatment includes infusion therapy, insertion of nasogastric tube, and after that enema. Do you know what is enema?
Yes.
Enema. Or for example, you are prescribed enema, but after treatment, the medical nurses answer your doctor, I tried to use enema, but when I insert tip of the from the enema in rectum, insert only maybe 400 milliliters or 300 milliliters, no more water, and all the waters pour out outside from rectum. It's test of segmental failure. It's maybe in case of volvulus of sigmoid colon, or cancer of the sigmoid colon, or cancer of the rectosigmoidal junction. Understood? What is this test of segmental failure?
Obstruction of the
Enema tube can
Enema.
go inside mother.
More than 400 ml.
More than 500 milliliters. When the medical nurses to use enema, and in the intestinal loops can pass non more than 400 milliliters, 4 or 5. Okay. One more sign, Cruvelier sign. Cruvelier sign. Cruvelier sign. It's theoretical sign. You can determine in case of invagination or intussusception. It's diarrhea which looks like jelly, red current stool, fecal matter, in case is intussusception or invagination. Ну что, хватит, наверное. Я отвечаю, у меня экзамены. Enough.